Niall Conroy, from UCD Centre for Emergency Medical Sciences, where on one hat I'm the medical director for the Advanced Paramedic Programme and the Diploma in Military Medicine. My other hat is as a doctor who spent a lot of the last few years living and working in low-income countries, in particular Bow Government Hospital in Sierra Leone. And I'm doing a PhD on neonatal care there. And I suppose what we've done is tried to formalise the relationship that I had with Bow Government Hospital and bring it into the UCD SEMS medical school sort of infrastructure. And that obviously has, a rich opportunity for positive benefits in both directions. But I suppose what I was asked to speak about were the difficulties. And what I would say to people were, the number one difficulty we faced was the unpredictability. I spent a lot of time in this hospital and thought we were very well prepared, but actually going in post-Ebola, the health infrastructure in Sierra Leone was broken, not to put too fine a point on it, and it was one of the most distressing environments I'd ever been. And this was after they'd been declared free of Ebola, So we got there with a lovely model of sort of neonatal training. We focus on neonatal health, but actually when myself and a GP colleague arrived, there were children literally dying constantly. There were babies dying constantly, something like I'd never ever seen in my life. And there was that big ethical dilemma about implementing your well thought out neonatal resuscitation, ongoing neonatal care program, and the fact that, at one stage we had 3 children in cardiac arrest within about 5 minutes. And so there are sort of ethical dilemmas that frankly, we don't have. I'm not here with answers to that or great solutions, but that kind of thing is unique to these clinical sort of partnerships that I gather. And then the other major, I suppose, stumbling block ongoing, and we will be no different than anybody else in this regard, is funding. We're sort of, in UCD SEMS, we're geared towards funding in the sort of pre-hospital environment with military stuff and ambulance stuff, and we're not tuned into the global health funding streams. As global, I've worked in global health departments before, and they're very tuned into those funding streams. And our administrators are different sort of outcomes. Our KPIs are all different, and so I suppose they would be the two biggest things: that the unpredictability of the type of environments that these clinical partnerships work in, and I suppose the ongoing access to funding.